My name's Helen Mutton. I am the founder of She Leads Health, and it's a safe LinkedIn group that celebrates diversity and is a great place to network. And everybody is welcome, men, women, what, anybody. Um, I am also excited to introduce to you my fellow She Leads team. It's Stacey Pritchard, Erin Gregory, and Charlotte John. So thank you for coming, guys. And also a huge thank you to IO Associates for sponsoring today's talk. But the most exciting thing is to hand over to our panel to talk about what we need to talk about today, which is our clinical safety. And in the interest of time, the guys are going to introduce themselves as they go along. So we're going to kickstart with Shelley. Shelley, would you like to introduce yourself and then share your story?
Hi everyone, good to see you all here today and thank you for coming. Yeah, as Helen said, I'm Shelley. I'm a nurse by background, also work as a clinical safety officer. And I'm one of probably one of many people that fell into digital health just through association with activities and things that we were doing on the ward at the time, sticking my nose into everything and generally just wanting to be involved. And today is really quite a hot topic, isn't it? You know, the notion of clinical safety stalling implementation. Because at the end of the day, you know, we're all here for the same purpose. We're all here to look after the welfare of the patients. And we know that technology, when implemented in the right way, can help us to do that. So therefore, we want the right systems to go live. And as clinical safety officers, we're not singing off a different hymn sheet as anybody else. You know, we all want the same thing. And what I've found from experience is that actually when clinical safety, when implementation stalls, often it's due to a lack of collaboration, not due to clinical safety activities. What we need to do is to get the right people in from the start and have some real thorough project planning. If you've got the right people together and we're all able to, you know, carry out our activities in tandem, then everything comes together in the end with that good thorough project planning to a point where everyone's ready at the same time. So an implementation should at that point run smoothly. So I'm just going to talk you through an example of when this was done really well. An old trust that I worked for, which again, Helen, you'll be familiar with. So my first role as a clinical safety officer was in a small foundation trust. We had really big ambitions despite being a very small team. And what we did was we got everybody involved from the start, as I just mentioned before. We had the goal of going live with an electronic prescribing system, and it was the first time that our trust had ever seen this type of technology. So it was big, you know, the change was huge. But we had pharmacy involved, we had nurses involved, medical, we got the frontline staff involved, which I'll talk about a little bit more in a minute. We also had the testing team involved, the IT team, everybody were all around the same table. And what we did to get the frontline staff involved was the clinical team on the digital, from the digital side. We ran weekly hazard workshops, and the manufacturer were really good with this actually, because they would attend that and they would help us with troubleshooting and things. And the staff would bring to us their use case. You know, what does this look like in our clinical area? What are we going to struggle with? And, you know, how will this work for us? And this enabled us to really start our safety activities of, you know, what is the use case? Is this piece of software going to support that? Do we need to change the configuration? What specific tests do we need to do? How do we know that this is going to serve its purpose? The other thing that we did was we called it tea and testing, and it was really fun. We actually went around the wards with a tea trolley and toast, and we supported the care of the patients so that the nursing staff and the doctors and the physios and anybody else that was there could go and test out our system. So once we got it to that stage where it could be used, that's what we did. And what this enabled us to do was to sort of identify areas where, you know, we got real feedback from the frontline staff. We could check that the configuration was right. We could identify training needs. What are they struggling with? What do we really need to pull out? We could look at what further testing requirements we had on the basis of, you know, it being used by those staff at that time. So that's a really good example of when clinical safety, if we're involved right from the very beginning, we can be doing our assessment in real time, in tandem with all the other stuff that's going on. and we can input to the configuration, we can input to the testing plan, to the training needs analysis, all of that stuff that ensures a safe implementation, but we need to be involved from the start. So on the converse to that is when, and I'm sure any clinical safety officer in the audience has experienced this, somebody comes to you and says, right, we've got this thing, it's ready, we want to go live next week. And you're like, whoa, wait a minute, what thing? I don't know anything about this thing. I can't, I need to go away. I need to look at it. I need to try and break it. I need to analyze it. And then I'll tell you if you can go live with it or not. But that's going to take me more than until next week. And, at that point, that team may say, well, we can't go live next week. Why can't you go live? Well, because the clinical safety officer, they need to do their thing. And they don't understand that actually, if they'd have come to us in the beginning and we'd have been involved from the start, our thing would have been evolving. Our assessment would have been being done the whole way through. So it's not the clinical safety activities that stall the implementation, it's the lack of communication and that lack of collaboration.
Absolutely. Absolutely. Brilliant. I was part of that with Shelley, so I have to say it was one of the best projects I've ever worked on, and I remember it fondly. So it was great. Thank you, Shelley.
Yeah.
So we'll save the questions for the end, but we'll move on now to Andrea so she can introduce herself and tell her story as well. Thank you, Shelley.
So I'm Andrea. I've also been a nurse for many years, more than I care to remember, 30 plus. And for those that remember it, back in the day, I worked on National Programme for IT, and I still bear the scars, and have the nightmares. But for me, I think I thought long and hard about, telling a story.
Mhm.
Actually, I have so many stories that it was how can I pick one? So I think I kind of like just want to talk about my journey a little bit of sort of and how that sort of and where the blockers or where the blocks were in that perhaps. So I started very, very early back in the day, where we identified, myself and a bed manager identified, where we needed an IT bed management system because we were sick to death of going around the wards with our clipboards 4 times a day going, what bed you got? How many patients you got going home? And we said the same thing 4 times a day and they lied to us. All,
Oh,
I know, shocking, isn't it? I know you're shocked. So we were like, we've got to come up with a solution to this. And IT, I'm sure, can help us, with a solution to this. And we did. And within 7 months, we had designed, built, tested, implemented an IT bed management system. It's amazing. And we actually got a HSJ award for it, because of how we'd actually given ownership of that system to the users. Because we felt that if we give them ownership of it, they're more likely to tell us the truth. And
yeah.
actually, if they can see the benefit of actually telling the truth and filling it out and all of these things, great, they're going to get the right patients at the right place at the right time. So that was one of the benefits. So for me, benefits is a really key part of clinical safety as well, and is an area that is very much neglected, I feel, sometimes in organizations, and we need to, do more of it. And I'm going to pinch something that from a conversation that actually Shelley and I had yesterday, and I hope you forgive me for this, but we were talking about something else. We were actually talking about change management. But it made me stop and think about what we said was the benefit of doing change management versus the risk of not. And I sat and thought about it and I thought, actually, let's think about clinical safety. The benefit of doing clinical safety versus the risk of not.
Yeah.
And that then started a whole, you can imagine yesterday then started a whole other thought process going on in my head. And it made me think back to all those times where I was seen as a blocker, not an enabler. And the way that I had to explain to people, these are the benefits. This is the reason that I'm doing this. This is why. Because at the centre of all of this is the patient.
Yes.
I'm quite passionate about clinical safety. I do apologise. You probably noticed.
I apologise.
The centre of all of this is a patient, and that patient could be me, could be you, it could be your mom, it could be your sister, your daughter, your son. If you can personalise clinical safety for people and get that message across, I think that breaks down a lot of barriers.
Yes.
You know, you can say to a CEO of a company, look, the reason I'm doing this is because, and one of my other favourite phrases is, if CQC was sat next to me now and they said to me, Andrea, go and find me the safety case for X, and I can't because it doesn't exist, I'm going to be in trouble. The CEO is going to be in trouble. If we don't do our job properly, you know, we not only are going to stall an implementation, but we're going to put people at risk. We're going to put ourselves at risk. We're going to put the CEO at risk. And I say, I've never been in a coroner's court. I don't intend to start now. And I don't, you know, and I don't want the CEO to end up in prison. So it's about protecting everybody, but at the center of it is that person and is that patient, and that's all that matters to me. And so if somebody says to me, Andrea, I want that safety case tomorrow, it's not happening. You know, it's because you can't. You have to do your job properly.
Yes.
And you have to, because you're there to protect the patient. So I could go on and on and on, and I could give you so many examples, but I'll give everybody else the chance to speak. But I am so passionate. And I just think that, like I said, providing that we keep that in our minds about the benefit of doing it versus the risk of not.
Absolutely. Absolutely. So good to have you here, Andrea. We'll definitely have some questions for you when we get through. So thank you. Right. So next person on my list is Natalie. You ready?
I'm ready.
Tag, you're it.
Thank you so much. And hi to everyone. Thank you for your time this afternoon. I'm a registered midwife, have been for 24 years, but I've had the most wonderfully varied career that's spun across the UK, United Arab Emirates and the Sultanate of Oman. So I've been a researcher, clinical audit manager, quality patient safety director, and a product owner for a UK health IT system manufacturer. So for the past 3 years, I've been a clinical safety officer, and it's wonderful to be able to look at that role from different perspectives. And I've loved that Andrea and Shelley have brought different approaches to answering the question, how do you prevent stalling during implementations? And I think I've had as a full-time CSO, I'm in a very privileged position where I do all day, every day, DCB 0129 and 0160 assessments. And what I've been able to do is kind of take a step back and have a look at where do things tend to fall down and why. So I thought that I would present sort of my observations to you today.
Thank you.
So I think the first thing that's gaining more and more traction, definitely more conversations, is that clinical safety belongs in procurement. And I think if you're quite far down the line of an implementation and a system has been procured and then the clinical safety team or clinicians get hold of it and it's not quite fit for purpose, or there's lots of configuration that needs to be made, I think we've missed a trick. So that could potentially stop stalling. I think we need to have a really solid clinical risk management process overarching all of this organisation-wide, so that people understand their roles and responsibilities. And one of the things that I've been doing more and more with my customers is bespoke training, which is running through what clinical safety is, but also taking role by role so that you can see where everybody does fit into clinical safety. There's no escaping from it. But, you know, from account managers through to developers, a critical part of clinical safety, your QA, your testers, but top management. You need buy-in from top management to set the tone in the organization. It's either going to be a tick box exercise or it's going to be embedded fully. And I think that makes a difference. So early engagement, as Shelley and Andrew have mentioned, but with the right people, key stakeholders, movers and shakers, people who can make decisions and unblock things as they arise. And if they're part of that journey from the beginning, there's that much more investment and therefore that chance for the collaboration. I think what's also really important is defining the scope of either the product that's being manufactured or the deployment, because the clinical risk management plan will inform the hazard log. And if that plan is inaccurate, we haven't thought about a particular aspect of functionality or the architecture or the hosting, the training needs, how we're going to approach user acceptance testing. If we find a bug, what do we do with that? Have we got good communication with the manufacturer so that actually there's a relationship there and we can have early discussions? Have we thought about data migration? And have we tested a disaster recovery and business continuity plan? So because the plan informs the hazard log is going to inform the safety case. And that's really where you're going to get your solid, either, yes, this is ready for release, or, a presentation of go, no go. So I think if you're then uncovering things, and part of having, as Shelley mentioned, the right people around you, what I've seen time and time again is that somebody wasn't involved in those initial discussions, get sight of a report or a hazard log, and then actually there's additions to be made or things to omit, and that can delay things. But one thing I've learned as well is that when you've got a hazard log and it's still in draft form, as the standard requires, do the traceability at that point, because it can really uncover what was thought to be in place, but actually is just a deeply ingrained process that hasn't been documented. So if we start talking about things like we've got this policy in place, we've got this disaster recovery plan, and actually it's not, that might delay things or cause you to revisit the hazard log. And again, that can be the difference between being seen as an enabler or a blocker. And I think that the other important thing is to create a schedule of meeting points where you discuss things so you're able to tackle them in a timely manner. And I think this becomes particularly important when you're dealing with things like release schedules. So if you're doing clinical safety and it's reactive, so you're trying to catch up with where the development changes, it can be that you're making releases, but your deliverables aren't ready at the same time. And I think as well, being mindful when a piece of software has been deployed, that actually advance notice is given so that NHS CSOs, as an example, who might often be seconded and it's not their full-time role, have the time to digest and consume those documents, work out whether those changes are applicable for them, and then update their own 160 materials accordingly, and everything that goes with it, the additional training needs, any kind of training materials, the testing, of course. So I would say they are my observations for where it's common to stall and how you might remedy that.
Yeah, I can't wait till we get to the questions. I've got loads of things to ask everybody. But that was really brilliant, Natalie. Thank you for that.
Thank you.
We'll move to Sasha now. You ready to tag in?
Yeah, I'm ready. Thank you very much. Thank you everybody for joining, and thanks to the others who have given their insights. I've actually made loads of notes, so if we don't get many questions, which I'm hoping we do, there's a couple of things that I'd like to tease out of that. So hi everybody, my name's Sasha Mullen. I've recently been appointed the CNIO for Frimley Health. I've been in the role for 3 weeks. But previously to that, I've been a clinical safety lead and CSO in a neighbouring trust for about 3 years. My career to date, 24 years as a nurse. quite varied. I've dabbled in anything and everything from sort of cradle to grave, not midwifery. That's the one bit I haven't dabbled in. But yeah, so I was some good experience sort of under my belt. But kind of fell into digital and fell into it in a positive way. You know, for A levels, I got an E, and I recently read in IT, and I recently read a report from school when I was going through the loft, and it said that basically IT was wasted on me. I'd never be able to do anything in the future, and look at me now, which is really good. What's quite interesting is that anecdotally, clinical safety is always kind of where I've worked within the NHS. It's always been badged as a blocker. It's always been an issue. It's like, don't let the CSO know because, oh, they're going to block it. They're going to say we can't go live. And in those kind of situations, I always think, well, had we been engaged at the very beginning, which, you know, the other speakers have mentioned, then we wouldn't be in a position where you're throwing a massive ream of information at us from all different angles, from different stakeholders saying, is it okay to go live? Well, I don't know. I can't make that decision, just like, you know, flipping a coin. So it has been really challenging in the NHS. And I think it still continues to be, but we do have some movers and shakers and people who are starting to really raise clinical safety to the top of the agenda in organizations. And we did touch on top management. And I think sometimes as CSOs, you need to be those sort of feather rufflers, because nobody understands what clinical safety is. We have been employed as sort of the delegated authority for, you know, the expertise on this. And I think sometimes we have to go really out of our comfort zone and actually knock on the doors of our top managers to say, by the way, I've been employed to do this. Do you know what it is I do? You know, and actually speak to the chief executives and speak to patient safety teams. Because I've found that clinical safety and patient safety, while our end goals are the same, we want to protect patients, make sure the care that's being delivered is safe, we work very differently to patient safety teams. We are a different team, and sometimes we're actually quite far removed. We still, as clinical safety teams, we still sit in the basements of hospitals or in units, you know, with no windows with the IT teams. And I go around and do sort of visits and see patients, and that people think I'm the IT guy. Can you help me with sorting out my PC? Well, actually, I do more than that, you know. So I think we need to do a lot more in championing what clinical safety means and what, you know, for our organizations and what we do as CSOs. I want to share a story with you as well in regards to, I've been in a situation where clinical safety has stalled a go live. And quite proudly, I was supportive of that. And hopefully the story will explain as to why. So when I started in my previous trust, I'd been in there maybe a month, and I was approached by a project lead and said, right, we are going to be rolling out this big system, and we just need your sign off. Here is 3 years worth of information. It's been on and off, contractual issues, funding, but we need it to go live. We need it to go live. Okay, that's fine. Let's see what we've got. Looking at what they had, no clinical risk management process was followed. It was all kind of temperature checking, which way's the wind blowing. Do we need to let clinical safety know about this? Maybe. And what happened was, restart, met with the project managers. Look, I'm new in the trust, and actually being new is quite difficult. I think you don't have the confidence straight away to challenge people in senior roles. And also when you're going to a project team lead or a project manager who's been dealing with this project, breathing it day in, day out for 3 years, and you're saying, you'll go live, you need to stop it for the moment, because actually what you're telling me, the risks are quite high, and actually we have no assurance, and we cannot reassure top management that this is a safe way of going forward. So it was an opportunity to sit and go, actually, we need to reset. I need to tell you what it is that I'm here to do. I need to see what you've got, and then we need to go away. We need to work together. Looking back, there was nothing. We were very much led by the supplier, I think, as an organization. The right questions weren't being asked. And once the supplier had informed us that, yeah, no, absolutely, we've got that, we've got this, there was no, again, traceability, no checking, actually, do they have that in place? You know, will, you know, God forbid the system go down, do we have the right things in place to support us as an organization? And once we'd done that resetting, I was challenged. Well, it's out in 3 other hospitals at the moment. It's working very successfully. So what do we need it for? We're going based on the others. Okay, well, have you reached out to the others? Have you got a sort of an understanding of it, of its working parts? And have you spoken to the organization? Have they had any incidents? Well, no, we just haven't heard that there have been any incidents, is kind of the response I got, which is like really, really difficult. And I think at that point, it was, okay, we'll just go end to end. We'll start from the beginning. So I'd informed them that we'll do the end to end. We'll do what we can, but I need at least 2 months. I can't do it any faster. And I mean, that's, dropping everything to do it. And it was my main role. Whereas other CSOs, I'm very acutely aware, a lot of CSOs have this as a tag along role. And I find it very difficult for them. And I think they find it very difficult when they're given CSO work, because it's very difficult to do it as an add along. But I think that's another hour's discussion, that one. So I think, once we've done that, 2 months was, okay, do that as a minimum, give it to you by then. So we did all the work. Now, when my recommendation came in that the system was not safe to be deployed, that was a different conversation. I was then told by the organization, it's going live whether we have your blessing or not, basically. As a CSO, that's quite difficult, because normally, most of the time, we get a good outcome from a lot of our safety cases. I believe, from my experience, we've always had, yes, there are risks, we can mitigate. We can still go live, but we have enough in there that we can keep our patients safe. But this one, I could not, with my hand on my heart, say, absolutely, 100%, let's go ahead, even with the mitigations we had. So very difficult conversations with the organization, so much to say that the clinical safety case report went up to the chief executive, and the decision was to acknowledge the clinical safety officer's recommendation. However, in light of other issues, they would be going live with said system. Now, I felt a little bit uncomfortable with that. However, I think sometimes it is okay. If the work has been done and you have poured your life and soul into it, and the outcome isn't how we anticipate it to be, as long as we followed process, as long as we've done a really robust assessment, and the outcome is, I'm not happy with that, fine. I think we need to get comfortable with going, that's okay, as long as the organization can demonstrate that they have taken on all of the assessment and they have made that decision against the clinical safety officer. And once that's done, my work isn't done, because I don't wash my hands and go, absolutely, I'm done now, it's a no. It's about, okay, you still want to go ahead. What can I do as a CSO? Further can I do to support the organization to make sure that even though we go live with it, that we keep it as safe as possible? So there are sometimes opportunities when you've said no, and it goes to a wider audience, because bad news travels faster than good news, that you get other people's eyes on it that wouldn't necessarily be part of your core sort of people for the assessment. What was quite interesting with this solution was that there was also a little bit of a national interest. It had been seen in other organizations. It had negative connotations, but as a CSO, that helped me. However, it didn't help the outcome. But from that quite long, rambly story, there are a couple of things that I think are really important for me, and learning for me, is that you've been entrusted as the CSO to do your job. And as long as you are following the process, and I appreciate, there's other bits to it, just that process. As long as you're following the process and you can get that confidence to challenge those in senior positions to say, I'm not happy with your decision, but I respect that. Can I just have it in writing? Then I think it may sort of help with some of the anxieties that we as CSOs feel. I'm only speaking in terms of the NHS, but I know there is a lot of anxiety out there, because clinical safety varies from organisation to organisation. We'd like to think that if we have a system that's rolled out and there's a really robust clinical safety assessment been undertaken, that we can reach out to our colleagues and share some of that learning. But I know, and we know, that we can't actually do that. We're not in that position to do that at the moment, because within the NHS, there's still that lack of buy-in, I think, from top management, which, you know, we've had a couple of times. And I think, I'm not sure, this is a question I think for later on, is what more can we do as CSOs and those working in the clinical safety space do to keep that momentum going in sort of raising and keeping that profile of CSOs on the agenda? Because clinical safety is a small part of a huge picture. It's a jigsaw piece puzzle, isn't it? We need that part of the jigsaw. We've got procurement, we've got this, we've got that. CS is in there as well. But you can't really do anything with our piece missing. However, there seems to be a loophole within the standards and the guidance that are given, that if we've said it's not safe, but somebody else says it is that okay? I suppose that's an open-ended question. Is it okay that we've done all that work and we've recommended it's unsafe, that can be overturned by somebody that should be supporting clinical safety and top management?
Yeah, interesting.
So I'm going to leave it there because I'd love to get some questions. But I suppose the other thing is, as well, is I've only got experience of clinical safety within the NHS. But I've learned a lot as well, actually, from suppliers and private industry, because I feel that there is a little bit of, so clinical safety, we know it needs to happen, but how are we making it happen across the NHS, and how are we getting that consistency? We're probably not right now, but I know that if I speak to one supplier and to another and to another, if I work with them collaboratively, I find that even though those suppliers have never sort of crossed paths, you're all doing it the same way and in a very sort of robust way. Whereas in the NHS, I find there are some barriers that we still need to break down to have that consistent clinical safety assessment and messaging. So I'm going to stop now because I could go on forever.
You've all said the same thing, and I could go on listening to you all forever. So thank you so much.